Portfolio Committee on Health has decided to adopt the National Health Insurance Bill. The NHI Bill was introduced in Parliament back in August of 2019, and it was then referred to the committee for consideration. The bill aims to provide universal access to healthcare in South Africa as enshrined in the Constitution as a fundamental right. For more on this now, I'm joined by the South African National AIDS Council Civil Society Forum's Dr. Matome Ganagha, who joins us virtually from here in Johannesburg. Doctor, thank you so much for your time this evening. Your organization has been banging the drum for the need for this NHI bill to get off the ground for some time now already. This must have been quite a moment for you and your colleagues. You must have been encouraged by today's development, or this week's developments, rather.
Good evening to you and to the viewers. Absolutely, we are quite elated because this has been quite a protracted journey, not only starting when the Green Paper was launched in 2011, but you can take it as far back as 3 decades ago when the update was launched, because we did have a mandate to address the injustice of the past. And the NHI Bill is a step in the right direction to ensure that we do close the gap on inequality.
Now, in reaction to this development, you were quoted saying, and I quote you, "Leadership characterized by solidarity from the social, economic and political elite is the ultimate key to the timely realization of the NHI Bill, which is restricted by the reality that those tasked with delivering this mandate are also, in the main, amongst the close to 9 billion beneficiaries of the medical aid schemes." Do you believe that that reality is the part of the reason why it's taken us so long to get to this point?
Absolutely. And I think it's best captured by a quote from a gentleman by the name of Thomas Sowell, who said it's hard to imagine a more stupid or a more dangerous way of making decisions than by placing those decisions in the hands of those who pay no price for being wrong. And if you look at the current structure of South Africa, those who are responsible for the health, the social, the political, and the economic elite in the public sector are almost universally, members of the medical aid schemes. So if a doctor, if a nurse, if a bureaucrat, even a politician, a minister, MEC, MMC collapses in a hospital, they will call an ambulance if they're in a public facility to take them to a private facility. So when you have a system that is governed by people in the main who do not use it, it does not create an incentive for, a speedy implementation of policies, although there is universal agreement, particularly in the space, although there are a few, particularly in the, some interest group and big business that are pushing back. But NHI is generally a supported bill.
I was in conversation with Dr. Poppy Ramathuba not so long ago. Of course, he's quite well known for various reasons as the MEC for Health in Limpopo. And she made a very good point saying that the reason why she's so hard on all of the little health facilities in all the hidden parts of her, very rural parts of her province in Limpopo, is because she made the point, especially to her colleagues in government, that if you end up in an accident on a road in the middle of nowhere, you're not going to be driven 3 hours to a major city to be able to take advantage of your medical aid and go to a private hospital. You're going to be helped by the closest medical facility that will probably be a government hospital. It's a very simple way of looking at things, but also a very practical and powerful one, isn't it?
No, it is a practical one, but more practical is that in South Africa, we've got a quadruple burden of disease, whether you talk about HIV and TB, maternal and child issues. We just saw the stats this week on violence, in the country, and of course, non-communicable diseases. And, when you have 85% of the patients who are overburdening the poorly, supported public health sector in terms of human resource for health, but also just through the burden, the finance ends up not being enough. It really does not make sense for a country that has so much to repair in terms of our historical context, just to have 15% of the population who are on medical aid, utilizing the bulk of the resources for health in the country in terms of the split of the budget, but more importantly, it is skewed to favor the private health sector in terms of the human resource for health. So it's not so much about an emergency, just in terms of the prevention, the health promotion, and the day-to-day management of chronic diseases.
You rightly pointed out that it was almost 3 decades ago where there was the acceptance and the adoption that there was a need for a national health insurance system to uplift and care for South Africans who for so long had not been cared for by the apartheid government in power at the time. But you also know that there are quite a few naysayers now 29 years on who raise their eyebrows as to whether the government or those in power will be able to pull off something as intricate and powerful as the National Health Insurance Bill. We've had questions asked by the SA Private Practitioners Forum. I see there's a report quoting the KwaZulu-Natal Doctors Healthcare Coalition, who all point to the underperformance. I suppose one could say that that's an understatement, the underperformance of government, especially, as you mentioned earlier, the departments of health in using the resources that they did have in the first place, mismanagement, financial mismanagement, and the list goes on. I don't need to tell you that. What do you say to people that say, but look at the evidence of the last 30 years. They haven't shown us that this is what they really want to do, to care for all South Africans in a decent way, as is their right, as enshrined in the Constitution?
Well, having quoted from earlier from Thomas Sowell, there's another Thomas fellow who made a famous quote to say, either choose champagne for the few or clean drinking water for all. And we have chosen champagne for the few. But that goes without, punishment, because when you look at our health expenditure and you compare us, even the budget declaration in 2011, it did declare that 15% of the national spend goes towards health. We've exceeded that, 10 years later. The share of the GDP, it's quite high in terms of what you spend, around 8.6% towards health. But if you compare our life expectancy to upper middle income countries, which are our peers, we're doing, not so well. Actually, our life expectancy sits around, 64. And if you look at those countries, it's around, a decade over, around 75. So we are paying the price for two-tier health system. And I think we have to distinguish between, principal issues as well as technical concerns that needs to be sorted. And it's quite disingenuous for the groupings that are pushing back to argue a point that is caused by the very two-tier system as a point to make why we should not move forward. Because I made the point earlier that when you've got the leadership of a system who do not use that particular system, you are then prone to maladministration and going all the way to corruption. I mean, if I know that I work at Mafikeng Hospital and I'm in the procurement, value chain, and I'm a card-carrying member of GEMS, which is the government medical aid schemes, I do not have an incentive to buy cribs and incubators, knowing very well that my wife or my partner, my girlfriend, is not going to give birth in that particular hospital. So these issues are not in a vacuum. At the primary cause of a lot of the maladministration, they're simply pushed by the fact that we have a system where the authority are not the users of the particular system. So there will be an incentive in terms of motivating. I'm not saying it's the only solution, but it will certainly be an incentive where those who use the system also govern the system, and those who govern the system also use that particular system. So, and these issues are also taken care of in terms of, the Presidential Health Compact. So it's not just participation along the public hearings, but since 2018, we've had 9 pillars of the Presidential Health Compact, which are addressing, amongst others, financial management, leadership and governance, issues of procurement, and engaging the private sector. And we recently, last month, went to the second national Presidential Health Compact that included, the 10th pillar of pandemic preparedness that further engages, but also reported on areas that have been, targets that have been met, progress where it has been made, and where progress has not been made. And this is a multi-stakeholder platform in which we are all putting our heads together, public, private, and civil society, in coming up with these solutions. So there are platforms to address and correct those concerns.
Okay, we're going to leave it there. I'm sure lots of conversations still to be had as we head ever closer to the next step in the process, in the adoption of the NHI. Thanks for your time this evening, Dr. Matome Kganagha from the South African National AIDS Council Civil Society Forum, joining us here in Johannesburg.